Excellent. Okay. So we're going to have about 6 questions on IRAEs, right? So the immune-related adverse events. These are really important, and we've been talking about them quite a bit, so I'm hoping that you feel very familiar and comfortable with these. So a couple of things, we talked about colitis and kind of when we intervene for colitis, when we hold, when we give prednisone. So I really want you to make sure that you understand, that we don't dose reduce these drugs. We don't necessarily switch them out. We just treat with prednisone if it's appropriate and hold if it's appropriate, and then restart or cancel it if it's appropriate, right? So the CTLA-4 drugs, if somebody gets, grade 2 or 3 or 4 colitis, obviously we're not going to re-challenge them. With the other drugs, the anti-PD-1s, anti-PD-L1s, it's a little different. And if they're, maybe at grade 2 diarrhea, we're not necessarily going to not use the drug again. So a lot of these questions will be very similar to the IRAC questions that I've had, that I've showed you, with maybe just like a tweak here and there. And in some cases, they may be the exact same question. Any questions on that? Okay. I'm also going to give you another table. I don't want you to panic. No, it's going to be okay. It's actually a really, really easy table. And it's basically just looking at the table and being able to figure out what labs you would need to order for at baseline and periodically for a checkpoint inhibitor. Okay. So it's, again, the important things to know here are what's the difference between a diagnostic exam and a laboratory exam? So really quickly, who can tell me what the difference is? Or is there a difference?
Lab exams are to monitor the patient, I think.
Yes, so lab exams are definitely to monitor. I'm thinking more about like when we draw labs, we're talking about like drawing blood, maybe doing like a specimen or something like that, right? When we talk about diagnostic tests are things like echoes and MUGAs and pulmonary function tests, right? So if we're testing organ function and we're using some kind of apparatus to do that or some kind of scan, that's a diagnostic. If we want to do labs, then we may be checking things like serum creatinine and, calcium and LFTs and things like that.
So wouldn't it depend on what medication you want to use?
Yes, it does depend on the medication. But in this case, I'm just going to give you a table specifically based on the incidence of some adverse events, which kinds of labs should you be drawing for the patient. And these are things we've already talked about, right? So what's that?
Okay, I gotcha. Yeah.
Okay, yeah. So we've talked about like all the itises that can happen, right, with these checkpoint inhibitors. So we've talked about thyroiditis and hepatitis and nephritis and hypophysitis, right? So those kinds of things. And it's going to seem when you see the question, it will be very obvious. I just don't want anyone to panic, because I do want you to get into the habit of being able to look at a table and feel comfortable with the information. So the other piece of advice I want to give to you guys for this exam is please read the question. I give you a lot of clues. Read it carefully. If you need to read it a couple of times, do it. You'll have plenty of time. So I don't want you to panic and be like, I see a table, I've just got to answer the question. Digest it. You'll definitely have enough time for it. Okay, any other questions on that one? Okay. We talked a lot about hypothyroidism and hyperthyroidism. So I'd like you to be able to know kind of when we, what we do for patients who are having thyroid abnormalities, right? So we talked about when patients are having like really mild thyroid problems, like hyperthyroid, we don't necessarily do anything different, right? We just continue the drug and, just maybe reevaluate or watch patients, versus if someone's having, kind of grade 3 toxicities like rapid heartbeat, hyperthermia, things like that, then obviously we might hold the drug and potentially give them some drugs to help with symptoms like propranolol and then also methimazole. But generally we don't need to do that because your thyroid will burn out. So then I want you to make sure that you also understand that for hypothyroidism, we just supplement everybody for the most part. And we start doing it as soon as the patient's starting to have thyroid, TSH abnormalities, as well as having some symptoms. And we kind of talked about, I think the question was asked, why don't we just start off giving the patients thyroid, levothyroxine or something like that in the beginning. And we know that it will happen, but it does happen a little bit differently for everyone. And the timing is a little bit off for everyone because it's individual. So we don't necessarily have to worry about, starting someone before they have symptoms or their TSH is rising. Any questions on that before I move on? Okay. We also talked about pneumonitis, and that's an important one. We talked about what to do for, grades, especially grades 2 and 3 pneumonitis, because those are really kind of the danger zones for patients. So I want to make sure that you know what we should do for grades 2 and 3 pneumonitis for a patient, especially as it relates to the steroids that we're going to give, how we're going to give them. Are we going to give them IV or PO if somebody's grade 3? And also, at what point do we use infliximab, right? So we talked about the TNF inhibitors being highly effective for helping to prevent some of that interstitial swelling and inflammation that happens as part of that immune response. And then also know when we don't need to give things like the empirical antibiotics or mycophenolate. I think there's one specific slide that kind of talks a little bit about that grade 2, 3 pneumonitis and kind of what we do for that. And this was also an IRAC question. Any questions on that? Okay. We also talked about how we discontinue steroids for patients who maybe have an adverse event and then they need steroids to help calm their immune system down. So can anyone describe how we do that? Do we stop abruptly or do we do some kind of protocol? And what term do we use for that?
Taper.
That's right. We do a taper. We do a taper because we don't want patients to have a rebound effect from withdrawing the prednisone too fast or the steroid too fast. Awesome. Thank you. Any questions on that? Okay. Let's see what else. So yeah, I talked about that. All right. So then shifting gears to breast cancer. You definitely need to know the molecular subtypes, right? So we talked about luminal A, luminal B, but those are always estrogen hormone, receptor positive. And that luminal B additionally sometimes can be HER2 positive. We talked about what does HER2 enriched mean, right? So that means you're overexpressing tons of HER2, but you're not overexpressing the hormone receptor. And then we talked about triple negative, where you're not overexpressing any of those receptors. And that makes it a little bit harder to treat because we have to use different drugs. And we also tend to see that in those particular patients, they often will have a higher risk of the BRCA mutations as well. So specifically, I want you to be able to identify, based on the molecular histology, luminal A, luminal B, HER2 enriched, et cetera, what drugs we might use just based on their MOA. So nothing complicated, nothing like, I have to figure out if this first line therapy or second line therapy. Nope. I just want you to be able to recognize what kind of drugs are appropriate and indicated based on their mechanism of action. So we know that Herceptin works against HER2. We know that things like tamoxifen and Femara and Faslodex and other drugs work against the hormone receptor. So that kind of question I will ask, and it will be very clear. Any questions on that? Okay. I also do want you to know or remember the indications for an oncotype test, because that's really an important part about how we decide if we want to treat somebody with chemotherapy early, right? Because that talks about it gives us an idea of their risk of recurrence for patients who have earlier stage breast cancers. And so we only use the Oncotype DX, obviously, in patients who have some kind of hormone receptor positivity. So they can be either luminal A or B, right? Any questions on that? Okay. Let's see. And then we talked a little bit about kind of wrapping up the breast cancer. We talked about goals and some of the drugs that we might use in stage 4 patients, or some of the treatment modalities. We talked about bone modulating agents. We talked about we might use radiation therapy, palliative care, things like that. So I'd like you to be able to kind of recognize some of those bone modulating agents that we use that we know help prevent pathologic fractures. Incidentally, and this is just an aside, so this is not part of the exam, but this is just an important and interesting thing that has happened recently. We are actually starting to encourage oncologists to prescribe Zometa and some of the other bone modulating agents as adjuvant therapy for earlier breast cancer, because we are seeing that the risk of recurrence does decrease. So we'll probably start seeing that drug occur more in much earlier stage breast cancer patients. But for the purposes of this exam, I just want you to be able to recognize some of the modalities that we use for patients in the late stage breast cancer. Any questions there? Okay. Mammogram screening recommendations. I want you to remember those. They're very important. So we offer them at 40, right? And we encourage them when patients are 45. We encourage them to do them yearly. And then when you hit 55 to 74, we say you can change to every other year if you want. And then we only continue them after 74 if patients have a life expectancy of 10 years, right? So these are things that are really important, because your patients may ask you, and it doesn't matter what setting you're in. It's a really important thing to know. And also for all of us who are women, this is an important piece of information for us too. All right. And then I do want we talked a lot about the monitoring that's needed for some of the bone modulating agents, right? We talked about dental exams and some of the labs that we worry about just based on the way the drugs work. So I do want you to be able to know that. And do you have any questions about that so far? Okay. Let's see. Also, I'd like you to be able to recognize the immunogenicity risk of a lot of the drugs that we use in breast cancer. So specifically the adriamycin Cytoxan combination, the taxanes, including Abraxane. That's really important because these drugs are used all the time. And I think you guys are probably at this point really great with carbo. So I don't have to emphasize that, but I do want you to make sure that you understand the immunogenicity risks of some of these drugs. Any questions on that so far? You guys are so quiet today. Okay. Yes. So we also talked about cardiotoxicity of the anthracyclines, so specifically doxorubicin. So you need to know the cumulative lifetime dose for doxorubicin with or without radiation to the chest, okay? Because if we give radiation to the chest, it's lower. So I need you to be able to remember that and potentially kind of calculate the remaining dose of doxorubicin that a patient can have. All right. Let's see here. I would like you to know some of the side effects of Cytoxan, specifically when we're administering the drug and some of the other potential issues that can happen when we give somebody Cytoxan. I'd also like you to be able to tell me what kind of monitoring is necessary for a woman who's on tamoxifen or an AI. And also really important to know about some of the drug interactions, specifically with tamoxifen and that 2D6 inhibition or drug interaction. Okay, I think that is it for breast. Yes. Okay. So before I shift to ovarian cancer, any questions? Okay. All right, bevacizumab and VEGF inhibitors. We talked about them. We talked about when we have to hold them, and then when we can restart them for patients who are having surgery. So I need you to remember that. It's really important, and also why we hold the drug when patients have to have surgery. And that one should be pretty straightforward. Also want you to be familiar with the drugs that tend to cause allergic reactions and when they happen for patients on receiving chemotherapy and ovarian cancer. So we talked a lot about platins, we talked a lot about taxanes, things like that. Any questions so far? Okay. Next, we talked about intraperitoneal chemotherapy and kind of which patients are appropriate for receiving. Sorry, that's dog food being poured into the background, into my dog's dish. So we talked about which patients are eligible for receiving intraperitoneal chemo because it's really toxic. They have to be healthy, have a good ECOG score, not have any problems like diabetes, things like that. So I want you to be able to look at a patient case and decide if that person is appropriate or not for intraperitoneal chemotherapy. I also want you to know the definition of platinum resistant and platinum sensitive. So we had a time cutoff there. So I need you to know that time cutoff. We also talked about pre-medications that are really important for paclitaxel to help prevent allergic reactions and things like that. So I want to make sure that you remember kind of the combination of drugs or drug that we use to prevent those reactions. Definitely need to know the mechanism of action of some of the chemotherapies that we use for ovarian cancer. So we talked about the platinums, the taxanes. We also talked about topotecan, and we talked about a couple of other drugs as well. Any questions so far? Okay. All right, so lastly, moving on to prostate cancer. Woohoo, we're almost done, guys. This is exciting. Okay, so we talked a lot about different kinds of castration. We talked about, medical castration or chemical castration and also surgical castration. So I need you to be able to identify, what types of castration or what, right? Drugs versus surgery. And then also we talked about when we give drugs like leuprolide or goserelin, what kinds of medications we need to combine for the first, 7 to 14 days of therapy to help prevent testosterone flares that can happen from these agonists. So I want you to be able to recognize when we need to add those drugs or give them together. Also, because this is important, I want you to be able to remember the age at which we start recommending doing a PSA screening, and also things that can falsely elevate or lower PSA as well. We kind of talked about that. We talked about some of the drugs that can falsely lower PSA. We also talked about certain activities or even medical exams that can falsely elevate PSA because it's a highly sensitive, inflammatory response that can go up or down based on what we do. And also I think it's slide, I'm going to probably quote this wrong, but I thought it was like slide 19 or 20 on that, on the PowerPoint. But we talked a little bit about, which kinds of therapies are appropriate for patients who have visceral metastases versus patients who don't have visceral metastases. So I'm not going to go into like second line subsequent therapy, but I do want you to basically recognize that like Provenge, for example, we're going to use in somebody who's basically healthy, who doesn't have any visceral mets, or, cabazitaxel we use after somebody has failed docetaxel. So just kind of some of those clinical pearls that we talked about, but nothing crazy, no dosing, nothing like that. Any questions about that? Okay.
Yeah, I think it's slide 20. I think it is slide 20. Mm-hmm.
Yeah.
Okay.
Perfect. Thank you. I appreciate that. Yeah, I was like doing it from memory, but everything blends together after a little while. Okay. And then also we talked about, so some of the toxicities related to the anti-androgens, especially like the hepatotoxicities. And then also I want you to remember kind of what testosterone level we're striving for when it comes to using these anti-androgens and the androgen deprivation therapy to try and maintain this, hormone deprived environment for as long as we can to help prevent progression. And then also, I want you to be able to recall some of the potential drug interactions with like flutamide. And that's, let's see, that's about it. Yeah, that is it. So any questions before I stop recording?
Sorry, what was that thing that you said about slide 20? You said you wanted us to recognize what drug, depending upon if they have like visceral versus not. Is that what?
Yeah. So like we talked about, so like radium-223, we talked about they had to have no visceral metastasis and have painful bony mets. Mm-hmm. We talked about Provenge, you have to have a good ECOG score, no visceral mets, things like that. So nothing really like crazy, but just kind of have a sense of if you look at a patient case and the patient isn't doing well, maybe has a poor ECOG performance and visceral metastases, it's going to be pretty obvious which ones you should not pick.
Okay, cool.
Yeah, mm-hmm. Sure. Okay. Any other questions? And remember, I will be around for office hours. So if you're just resting and digesting at this point and are in like an exam review torpor, we can always, you can ask questions anytime. And I'll answer, of course, over the course of the weekend. And I'll try and find a time where I can pop on and be able to answer any questions for you guys. Wow.
Could you clarify between you said the medical, the castrations between the medical, surgical, and the chemical?
Yeah, so medical and chemical are the same one. Sorry about that. Okay. So surgical castration is...
Okay, that clears it up then.
Okay, I'm sorry.
Fine, thank you.
Yeah, no problem. Cool. Any other questions? Are you guys doing okay today? Everybody seems pretty, I don't know if you're just exhausted because, pandemic and all kinds of other things, or you guys are burned out or stressed out. All of the above? Yeah. Is there anything I can do to help? I can tell you really bad jokes, but I don't know that many of them, actually. I can tell you that I did add a pretty funny choice in one of your questions, one of your test questions. My wife helped me come up with it. It's pretty hilarious. We had a good laugh about it last night, so I hope you will enjoy it as well. Okay. All right. Well, so the plan is going to be this. So I'm going to finish doing a little bit of tweaking to the exam, making sure that all the language makes sense, nothing's confusing. And then I'll go ahead and upload it into exam7, make sure everything's keyed properly. And then I'll send you an email at some point tomorrow. It'll probably be tomorrow, later afternoon or evening, that it's able to be downloaded. And we'll, send out the password, obviously, right before we start. With the hour and a half, I hope that not only does it help you take a step back and read the questions, don't panic. I promise you've seen these questions before. We've talked about it. We've talked about the questions in our applications, in our IRATs and the quizzes, and the PowerPoints and everything. So there's not going to be anything that you haven't seen before. And then if you do have any tech problems or anything like that, obviously reach out to me and Dr. Fox, and we'll see what we can do to help. But I'm hoping that this testing experience will be better for you than the last. And again, I'm here to answer any questions, anything that you need, as much as I can.
As a small note before you guys all leave, the exam download time ends at 2 p.m. So make sure you don't log on to exam7 at 1:59 and expect to download the exam. Please do that in advance. Get ready. I don't want you locked out of being able to download the. And then if you do have any technical difficulties, please let us know as soon as possible. We do monitor the start and the stop time for all of you, so please start the exam on time. It helps us make sure everything is flowing properly. There is a cutoff time for the exam upload. So if you don't start on time, you might get stuck at the cutoff time, which is at the end of the hour and a half. So, make sure you are starting and ending on time. And if you do have problems, please let us know so that we can make adjustments for you.
Yes, we're here to help. I promise we're not dementors. We're not demented either. Not yet, anyway. Getting there, though.
Dr. Leva,
yes.
The last class we had with you, and we were going over the quiz, and you kept getting interrupted. So I think some of the questions, I'm not sure if I got the answers correct, so I can touch base with you. Or if you want to go through it, I don't know if other students wanted you to go through it again.
And I'm sorry, this was the quiz, not yesterday, a couple days ago?
Yeah.
I read a couple days ago? Okay.
Yeah.
Yes. Let me see if I can get onto Brightspace. That's the only problem. So one of the things I can do is, if I can't get onto Brightspace right now, then what I can do is,
I can get on, Dr. Leva, if you want me to share screen and pull something up.
Okay. Let me,
if you can't.
Yeah, no, thank you. I'm hopeful I can. Was this the lung cancer one, or I'm sorry, or was it colon cancer?
Okay, I think it was.
It may have been the first day that I had internet problems, which I think was Tuesday.
Yeah.